Hello everyone. Today I'm going to talk about hydronephrosis, nephrolithiasis, and renal neoplasms. This will complete your kidney chapter. Okay. And yesterday, as you know, we have spoken about. Yesterday we have spoken about the cystic disease, the congenital malformations, and the vascular diseases which cause the renal pathology, right? So I'll just have a recap of what we have talked about yesterday, that is congenital malformations of the kidney. As you know that like any other organ, the kidney is developed. So any abnormality in the development of the kidney will cause a congenital malformation. So it can be amounting to the amount of the renal tissue that is present, that can be renal agenesis or hyperplasia, or it can be related to the formation of the position and the structure of the kidney, that will be related, for example, horseshoe kidney and renal ectopia. According to the position, if it is misplaced, it can the renal function can be retained, but it can be prone to infections. Then there is something known as the differentiation abnormality that is associated with the cystic disease of the kidney, right? So the cystic diseases of the kidney can be congenital or acquired. We have seen that it can be neoplastic or non-neoplastic. So we have seen about the multicystic renal dysplasia, wherein there is immature cartilage and immature mesenchyme associated with the abnormally formed tubules that is accounting for the multicystic renal dysplasia. And we have seen two important things, that is the adult type of polycystic kidney disease associated with the PKD1 gene and PKD2 gene, and the age of presentation, adults, and lobulated appearance of the kidney with the cortex and medullary involvement, right? So this is about the adult polycystic kidney, and the infantile polycystic kidney disease having the abnormality of the genes again, and the age of presentation is less. And usually it has a smooth surface grossly, and whatever is involved, the differentiation can be present until the structures are totally obscuring the renal parenchyma. So this is about this, and acquired cysts can be seen associated with dialysis and urinary tract obstruction and carcinomas involving the renal parenchyma and the renal pelvis. Okay, so after that we have seen about the vascular disorders. Vascular disorders, we have talked about the benign nephrosclerosis, that is the hypertension, which is usually benign, less than 180 systolic and 120 diastolic, and it can cause the renal involvement. It can be directly causing renal involvement, or it can be associated with the systemic disorder, right? So it is usually causing high-end type of arteriosclerosis. There will be the glomerular sclerosis associated with it. So this is about the benign nephrosclerosis. and malignant nephrosclerosis. You see that there is more of hypertension, more than 200 by 120 mm of mercury. So what is happening in malignant nephrosclerosis is that there can be sudden onset of increased hypertension. It can be seen from the normotensive individuals, or it can be having a pre-existing benign nephrosclerosis. So what happens is that because of the sudden onset, there will be ischemia. So there will be fibrinoid necrosis pertaining to that, and there will be onion skimming or smooth muscle duplication. Okay. So this is leading to hyperplastic arteriolosclerosis. So because of that, what is happening, sometimes it can go into hypertensive crisis, leading to cerebellar edema, papilledema, encephalopathy, and all of those things can be involved. So headache, vomiting, nausea, everything can happen with malignant crisis when there is involvement of malignant nephrosclerosis. Because you know that kidney is an important organ associated with maintenance of the hypertension, that is the renin-angiotensin system, right? While we are talking about the vascular disorders, we also spoke about the vasculitis, that is small, medium, and large vessel vasculitis. It is same as a chapter of the blood vessels, but then you have to know that the vasculitis can also cause possible type of rapidly progressive glomerular nephritis. So even this can cause the disease pathology involving the renal parenchyma, renal vessels. Okay, and something else we have seen is diffuse cortical necrosis. That is an obstetric emergency that happens because of that there is diffuse, as the name suggests, diffuse cortical necrosis. That is fibroid type of necrosis involving the total kidneys. It can be seen in abruptio placenta, and okay, whenever there is a placental breach and excessive bleeding, this can happen. So while we are talking about this, we are continuously using the term fibroid necrosis. Fibroid necrosis is nothing but the cellular detail is lost and then it becomes eosinophilic and smudgy. Okay, this is about the fibroid necrosis. So after seeing all this, now it is time for us to look into the other thing, that is hydronephrosis. Hydronephrosis, the term is usually related to what? It is like the dilatation, there is some fluid accumulating in the renal parenchyma, where the term we call as hydronephrosis. Okay, so there is dilatation. Why there is dilatation? See, imagine you are filling a balloon with a pump, okay, of water. You know the water filled balloons, what will happen? You are trying to pump it. It will enlarge. So if you take bladder as something that is balloon with water, when you fill it completely with the water, what happens? It sags, and beyond, if it is sagging, two things happen. Either it bursts out or it can cause pressure on the pipe with which you are filling the water. So the same thing happens here with the kidney. Whenever there is a partial or intermittent obstruction of the renal pelvis, then what happens? The formation of the urine, what is there, will try to blow out the kidney. So there is dilatation that is happening because of the obstruction. So usually the hydronephrosis is accompanied by hydroureter. As usual, it will be primary or secondary. With the definable cause, it is secondary. Without a definable cause, it is primary. So primary hydronephrosis usually encountered in children. Usually it can be a congenital defect when there is an obstruction in the pelvic-ureteric junction. Okay, usually this is about the obstruction leading to the neuromuscular problems. Okay, you know that whenever there is coordination between the nerves and the muscle, there won't be normal functioning of the muscle taking place. So because of that, there will be some spasmodic segment of the circular muscle that is having a constriction effect, and then there is imbalance between the sympathetic and parasympathetic system. So because of that, what happens? There is obstruction to the passage of the urine and thereby primary hydronephrosis. When coming to the secondary hydronephrosis, it can be unilateral or bilateral. Okay, I think you all know that we have two kidneys, right? So if it is bilateral, it is involving both the kidneys. It can be due to some secondary causes, that is definable causes of urethra and prostate or bladder. Then unilateral causes wherein there is some extramural effects, intramural effect, or a luminal effect. So what are the things which will cause the extramural? So there is obstruction of the inferior renal artery. If there is a pressure because of carcinoma cervix, prostate, rectum, retroperitoneal fibrosis, so some external pressure which is happening on the ureter. Intramural is usually congenital, which is having the pelvic-ureteric junction obstruction or atresia. So it can be acquired. There will be inflammatory stricture, trauma, neoplasms of the ureter or the bladder, which will cause the secondary hydronephrosis. If it is luminal, it is like the lumen. If there are some congenital folds acquired, there can be some calculus. So three types of the unilateral secondary hydronephrosis: extramural with the pressure and obstruction of the inferior renal artery. Then the second one is the intramural with the neoplasms. See, anything which causes the pressure causing the obstruction. Okay, it can be inside the lumen, inside relating to the ureter and bladder, or it can be related extramurally, just causing the direct pressure. So what is causing bilateral hydronephrosis? Again, it can be congenital or acquired with a pinhole meatus. There is no proper excretion happening, phimosis related to penis, bladder stenosis, and malignancies, right? So what is the pathology? It is gross changes in microscopic changes. What happens initially, anything which is like blowing out, initial thing occurs at the neck, right? So the same thing happens here with the pyramids of the medulla. The kidney gets suffered, then later the cortex will get involved, and finally the cortex gets thinned out, and then because of that the calces are blunted. So what are the microscopic changes? The microscopic changes are, in the early stage the tubules are dilated, obvious. Then as they dilate, then they'll lose the function, and thus the tubules get atrophied because they're not actually functioning. Then because of that, the glomeruli, which are comparatively intact, will be more in number due to parenchymal atrophy. Okay, that means that it can be appearing that because of tubular atrophy, they appear to be normal and even more in number. After 3 weeks of complete obstruction, the function of the affected kidney will be irreversibly damaged. So within the 3 weeks, you have to take an action. So what are the clinical features of a unilateral hydronephrosis? Females are more commonly involved. Right side is more commonly involved. Can be due to renal colic, hematuria, calculus obstruction. And how is the presentation? How the patient comes to you? It can be 3 types. Okay, one is insidious onset, second one is acute colic, third one is intermittent. What is insidious onset? Unilateral, dull aching loin pain aggravated by water intake or alcohol. The second type is acute colic, where you have acute renal colic pain with no palpable swelling. The third one is patient complaint of acute pain, then decreased renal output, and then swelling in the loin. And this is followed by polyuria, diffuse renal pain, disappearance of the swelling. So there is pain, swelling, no swelling. So that is intermittent, acute pain, and that is no swelling, acute colic, insidious onset, dull aching pain aggravated by water and alcohol. Investigations, X-ray, IVP, retrograde urography, and ultrasound. So what do you treat? How do you treat? Antibiotics, you treat the infection if the UTI is causing the damage, or prompt drainage should be provided for the urine so that if there is an obstruction or something, you can correct the cause. Then relief of the lower urinary tract obstruction can be done by catheter drainage, urinary diversion, indwelling pigtail with that catheter, or else if the hydronephrosis is irreversible more than 3 weeks, having a renal damage, then you have to do a nephrectomy. So what did we discuss till now? Hydronephrosis, which can be primary, secondary. Okay. Then we get to know that it is unilateral, bilateral, unilateral, extramural, intramural, luminal. Then we got about the bilateral causes, that is pertaining to the bladder or urethra, prostate. Then we saw that there is gross appearance of, initially there is the dilatation, then there is atrophy, the cortex will get thinned out, then renal pyramids are the ones which are getting damaged first. In the microscopy, you're finding the tubular dilatation, tubular atrophy, the glomerulus remain. The number may get increased as we see as the glomerulus function is intact. Then what we see is the microscopy is that. And then how do you find the patient is 3 types of clinical presentation: insidious onset, acute colicky pain, and intermittent pain. And now we got to know the treatment, because you have to treat the cause. Within 3 weeks, the damage is reversed. So coming to the other one, that is nephrolithiasis, lithiasis stone in the nephro, that is urinary tract. It's a frequent problem. When do you think this happens? When there is less water intake, when they're usually seen in summers, there is decreased urine output. Usually the crystallization has to be stopped in the urine, that is concentration of all the salts and whatever we are getting reabsorbed. So that should be stopped. If it is not stopped, it will form a stone. So when it is more commonly involved, leakage is 20 to 30 days, familial hereditary predisposition, boriness of metabolism, gout, dysuria, hyperoxaluria. Okay, what are the causes and pathogenesis? We'll see. Firstly, let me tell you the types of the stones. Okay, 4 major types involving calcium, triple phosphate stone, uric acid stone, and cysteine stone. In calcium, you have calcium oxalate stone or calcium phosphate stone. Calcium oxalate stone usually is in vegetarians whenever you take more green leafy vegetables and all. Phosphate stones are usually seen as a result of intake of more dairy products, that is usually seen in children. Triple phosphate or struvite stones are usually associated with urinary tract infection with protease type of organisms which cause the ammonia splitting. And uric acid stone, whenever there is acidic pH of the urine, it can be associated with gout, hyperuricemia, or if it is not associated with that, it will be leading to the tendency of the urination to excrete the urine, which is of the pH less than 5.5. The cysteine stones. So these 4 types of stones we'll see. So what makes a stone? Organic matrix of mucoprotein, that will be around 1 to 5% of the stone. And now we'll know how the stone formation initiates, then it propagates. So the most important determinant is that there is something called a supersaturation that is happening. So if, for example, you kind of try dissolving in milk, you take some Bournvita or Proteinix or something. Okay. You kind of try to put that powder in the milk. Then you try to dissolve it with a spoon. Then after some time, you kind of add more and more Bournvita, more and more Proteinix. What happens? There will be some Bournvita or the Proteinix or whatever you use will be floating, right? It won't get dissolved because it's super saturated. Same thing happens in the urine. So some substance in the urine, either calcium, cysteine, or uric acid, or whatever, is just getting more and more concentrated. Okay. When it gets if I add more milk, what happens? Obviously, it can dissolve it. So water acts as that milk. Like, if you're drinking more water, no concentration happens, and then there is no stone formation, no crystallization happening. Okay, so low urine volume is another cause. Supersaturation is one cause, low urinary volume. Changes in the urinary pH. Acidic pH, uric acid, alkaline pH, many types of stones can occur. Presence of bacteria, something like protease. Then now coming to the individual stones. Calcium oxalate stones, 5% of them have both calcemia and hypercalciuria. I have to tell you that calcium oxalate stones or calcium stones can be formed because of hyperoxaluria or hypercalciuria in spite of having hypercalcemia. So it's not completely a metabolic rearrangement. So 55% have only hypercalcemia without hypercalcemia, 20% associated with hyperuricosuriia. 5% associated with hyperoxaluria, which is hereditary acquired. Acquired is seen in enteric hyperoxaluria, that is seen in vegetarians. Hypercitriuria associated with acidosis produce calcium stone, or it can be related to idiopathic calcium stone disease. So coming to the other stone, that is magnesium ammonium phosphate, a mixed of struvite stone, usually from large stones because of it's called a staghorn folliculi, which can actually occlude the renal, renal parenchymal disease can be caused because of that occlusion. Okay, so because of that, it can be one of the cause of hydronephrosis. So formed mainly after infection by urea splitting bacteria. Resultant is that alkaline urine because of precipitation of what? So supersaturation of what? Magnesium, ammonium, phosphate salts. So coming to the third one, that is uric acid. Hyperuricemia, serum gout, and rapid turnover like leukemias. More than half of the uric acid stones neither have hyperuricemia nor hyperuricosurias. So it's not always the increase in or the supersaturation, but it can also because of other causes like acidic urine and low urine volume. Unexplained tendency to excrete urine of pH below 5.5. They are usually radiolucent. So these are the stones what you are seeing here, which are just occluding the renal pelvis. So what happens? There will be dilatation and it can cause increased size of the kidney and thereby deteriorating the renal function. The one, the cystine stone, caused by the genetic defects in renal absorption of amino acids, including cysteine, causing cystinuria. Stones are formed at low pH. So imagine when you're reading about the stones, you have to know what are the type of stones, why they are formed, and then you have to know whether it is associated with alkaline pH or acidic pH. You have to know whether it is radiolucent or radio translate. You just know about this. So the major constituents are basically water influencing, we have seen. So the sometimes I have also told you that there will be no predisposing cause for the formation of the stone, but it can be just the congenital cause. So there should be some deficiency in the inhibitors of crystal formation in the urine, something like pyrophosphate, diphosphonate, citrate, glycosamine glycans, osteopont, and nephrocans. Okay. So what is the morphology? The stones, unilateral in 80% of cases, favored sites are renal pelvis, calcis, and bladder. Usually they have smooth, regular, jagged mass of spicules. Stone habit looks just the same way you need to describe. So clinical features, obstruction. So whenever there is obstruction, hydronephrosis can happen. Whenever it is obstructed continuously, you know what happens? Ulceration and bleeding. Small stone is more hilarious as they pass through the ureter and cause colicky pain because secondary infections. So how do you prevent this? You can take 3 to 4 grams of sodium, okay? But table salt and high sodium foods should be reduced because it competes with the catch-up from the absorption in the kidneys. Avoid intake of oxalate containing foods. During the day, drink fluids every 1 or 2 hours. Okay. Remember, increased water intake or increased fluid intake will reduce most of the infections because it is not getting concentrated. So that is about the hydronephrosis and the nephrolithiasis. Now coming to the main topic of today, that is the renal neoplasms. Renal neoplasms, like any other neoplasm, can be benign or malignant. The benign neoplasm is renal papillary adenoma, renal fibrum, hematoma, angiomyolipoma, oncocytoma. Malignant lesions, renal cell carcinoma, collecting duct carcinoma, neuroendocrine tumor, small cell carcinoma. We also know some congenital tumors associated with the renal, that is the Wilms tumor, which is seen in children of 2 to 5 years old. When we are dealing with genetics and the childhood tumors, we've already finished about this topic. So I'm just repeating what is Wilms tumor. Wilms tumor, it occurs in association with some syndromes. If you remember the Beckwith-Wiedemann syndrome, the macroglosia and hypertrophy, right? Enlarged organs, remember that? And then that is WAGR syndrome associated with the Wilms tumor, that is W, Wilms tumor enredia, G, the genitourinary abnormalities, R for retardation. So WAGR, Denny-Drash, Beckwith-Wiedemann, all these 3 syndromes are associated with the Wilms tumor, which is a congenital small blue round cell tumor associated with the kidney. Okay, how do you find that? There will be some small blue round cells. You can see that there will be some glomerular abortive tubules and globules when we are looking in the microscopy. So there will be some blastomal component. Okay, this is about the and immature mesenchyme that can be related to the Wilms tumor. Okay, so coming to the major topic, that is the benign tumors, that is the renal papillary adenoma, that is 7 to 22% of cases at autopsy. Know that the renal papillary adenoma is a benign tumor arising from the renal tubular epithelium. Usually it is small tumor, 5 mm, it is well circumscribed. Complex branching papilloma can be seen, but the cells are benign and uniform looking. It is associated with the genetic abnormality with trisomy 7 and 17. The metastasis can occur and early cancer can be seen in renal papillary adenoma. So before I proceed to malignant tumor of renal cell carcinoma, we'll also talk about angiomyolipoma. Angiomyolipoma, as the name suggests, is the hematomatous type of benign tumor that is happening in the smooth muscle cells, angio, that is the blood vessels, and the fat. So what you find is that there is a tumor which is situated in the kidney having increased number of blood vessels, smooth muscle cells, and fat cells. Okay, that is about angiomyolipoma. What is oncocytoma? Oncocytoma, as the name suggests, is the benign tumor forming the oncocytes. Oncocytes are nothing but those cells which are having abundant eosinophilic granular cytoplasm and a vesicular nucleus that is pushed to one side. So how do you find the gross of the oncocytoma? Is that the gross is mahogany brown or tan brown. Okay, so this is a clinical feature of the oncocytoma. You just look at the kidney, you find a tumor that is well circumscribed, and then you are finding mahogany brown color, and then by just seeing the gross you can say that it is an oncocytoma. Okay, remember that it is the tumor of oncocytes which are looking like abundant eosinophilic granular cytoplasm with vesicular nuclei. Now coming to the renal cell carcinoma. Renal cell carcinoma can be hereditary or it can be sporadic. Okay, it's a very popular tumor where it can mimic any kind of disease. So a patient comes to you with renal cell carcinoma won't complain of a back pain or something. Initially, he may say that he has some sort of infection, some sort of, you ask him an investigation, he may have headache, any kind of symptom can be mimicked by this renal cell carcinoma. So you have to go through a lot of investigations to actually go to the diagnosis of renal cell carcinoma, because you know that the renal parenchyma is associated with a lot of metabolic and excretory functions. So whenever there is a tumor, what happens? It can cause hypertension, it can cause polycythemia, it can cause anemia, it can cause a lot of things which can mimic a normal disease. Okay, so that's the reason why you have to do a lot of investigations to get to the diagnosis of the renal cell carcinoma. Usually older people, males are more commonly affected. There are some risk factors associated with it. If it is congenital, usually it can be associated with tuberous sclerosis, the tobacco smoking, cigarette, obesity, hypertension, estrogen, asbestos, and acquired cystic disease. So sporadic causes I told you. So coming to the familial disorders. Familial disorders can occur with renal cell carcinoma occurring in the younger individuals associated with some genes called as VHL genes, wherein there is von Hippel-Lindau syndrome associated with bilateral renal cells, renal carcinoma, and hemangioblastoma of the cerebellum. Okay, VHL is one. Second one is hereditary papillary carcinoma that is associated with the MET proto-oncogene, and hereditary familial carcinoma is also associated with TSC gene, that is tuberous sclerosis. So I told you have to do cytogenetic studies, genetic and histological studies to know the type of the renal cell carcinoma. So here we see that there is some sporadic papillary, sporadic clear cell, hereditary papillary, hereditary clear cell carcinoma. So VHL syndrome is usually associated with clear cell type of renal cell carcinoma. There is another few syndromes which can be associated, which are causing the familial renal cell carcinoma, as such papillary, hereditary papillary carcinoma with MET protoncogene. There is some other gene called as FH gene, that is fumarate hydroxylase gene, that is associated with again the hereditary leiomyomatosis of skin and uterine, and also the renal cell carcinoma of papillary type, which can be a severe form. Okay, so the other gene can be BHD gene, that is a bird hog Dubé gene associated with some other what do you call manifestations like acrocordons and trichodiscomas and fibrofolliculomas. So I told you about 5 genes associated with the renal cell carcinoma. VHL gene, von Hippel-Lindau, having clear cell carcinoma, hereditary uterine leiomyomatosis and papillary cancer, papillary renal cell cancer, that is associated with FH gene. Then hereditary papillary carcinoma associated with MET protoncogene. Then BHD, that is associated with renal cell carcinoma and also trichodiscomas, acrocordons and fibrofolliculomas. And the other gene, the tuberous sclerosis gene or TSC1 and TSC2 genes, it is also seen associated with that. So these are the genes which can cause a familial type of renal cell carcinoma. Okay, so histological types: clear cell carcinoma, papillary carcinoma, chromophobe renal cell carcinoma, collecting or belly duct type carcinoma. So here we see the sporadic papillary renal cell carcinoma, upper pole is usually involved, even in sporadic clear cell. So we have this activated MET gene associated with sporadic papillary. In the sporadic clear cell, we have loss of VHL gene, inactivated mutated hypermethylation of VHL gene. A hereditary clear cell, we have the VHL gene also involved, but the lesions are multifocal usually, and in the upper and also the lower poles. Hereditary papillary can be multifocal associated with activated MET. Okay. So the clear cell carcinoma is the most common type, histological type of renal cell carcinoma with 70 to 80% clear cells. Papillary carcinoma, multifocal in origin. Chromophobe carcinoma, clear cells means there is clear cytoplasm, right? In the papillary carcinoma, you find finger-like projections lined by the papillary type. Papillary means finger type, you know, they are lined by the cells, okay? And the chromophobe renal cell carcinoma, you find the pale eosinophilic cytoplasm, the perinuclear halo and prominent cell membranes, which account for 5% of the renal cell carcinomas. So usually it is the upper pole which is more commonly involved. Clear cell carcinoma arises from the cells of the proximal tubular epithelium. It is solitary unilateral spherical mass, varies in size, bright yellow-white because of the lipid accumulation. It can have necrosis, ischemia, hemorrhagic discoloration, and the margins are usually sharp. So it has a variegated appearance with hemorrhage, necrosis, ischemia, that is again red, brown, necrosis, you know, everything can happen. It can look yellow because of lipid accumulation. So these are the tumors of the gross. See this tumor, very large tumor, just situated in the upper pole, almost reaching to the middle pole, right? Is seeing the tumor here and then the tumor here. Okay, the tumor completely involving the whole of the kidney. So these are the gross types wherein you can see Okay, so this is the histological type of clear cell renal carcinoma where you're finding the clear cells and vesicular nucleus and prominent nucleoli. Here you're finding the papillary projections lined by the cells, right? These are the papillary projections. And here you're finding the chromophore type where you're seeing the pale eosinophilic cytoplasm and the nucleus here. Right? This is about the three types of the renal cell carcinoma. So what is the clinical course? Palpable mass, hematuria, may remain silent, large size acquire 10 centimeters, post-vertebral pain will be there. There can be some constitutional symptoms which are generalized like fever, weight loss, malaise, weakness. And there will be some metastasis even very early at the time of diagnosis itself, like 25% at the time of diagnosis itself, you can have metastasis to the lungs, 50%, bones, 33%. We can also see that there will be metastasis in lymph nodes, liver, adrenals, and the brain. So it is very important that you do a section, take a section of the renal vein while you are looking for the looking at the renal tumor, because you may have to know about the spread, about the checking the spread or to stage the renal cell carcinoma. So the average survival of the renal cell carcinoma 5 years, 45 to 70% without metastasis, 15 to 20% with renal invasion and perimetric fat. So that is about the renal cell carcinoma. Thank you. This is the end of the kidney chapter. I hope you just look back into your textbooks and read everything what has been covered. Almost everything is covered. So just go through what is important, right? Thank you very much for your patient listening.